really appreciate it because I actually didn't even know about the time-lapse map until she and I started talking about this. So, okay, I'm going to share my screen again. And I'm going to keep going. Okay, so we did that. All right, so now we're moving into the actual testing guidance. And so there are 3 types of testing that I'm going to cover. One is routine testing for staff members who are not up to date. The other is testing regardless of vaccination status for anyone who presents with symptoms or reports symptoms that are consistent with COVID-19. And then the last is going to be testing in the context of an outbreak. So first for routine testing, and I know Andrea covered some of this already, but just so you know, one of the things that we did see is we think that some folks are testing residents on a routine basis, even in the absence of an outbreak, and that is not recommended. So the only folks that need to be tested on a routine basis in the absence of an outbreak are staff members who are not up to date. There are a few exceptions, such as newly admitted residents and residents who've left the facility for more than 24 hours, and the recommendation is there for them to have a series of 2 viral tests. And if I say viral tests, that means it can be antigen or PCR. Sometimes, depending on the result of the antigen test, requires a confirmatory PCR, but we'll go into that a little bit later. But in general, it's really the staff members where most of the routine testing is going to occur. And routine testing of staff, again, who are not up to date with COVID-19 vaccination, should be based on community transmission level. Staff who are up to date do not need to be routinely tested, nor do those who have recovered from a SARS-CoV-2 infection in the past 3 months. CDC, and this is something that has been fairly consistent at least for over a year, which is that they think that folks who have been infected within the past 3 months are fairly well protected. And also, if you're talking about a PCR test, they're also likely to continue to test positive for up to several weeks afterwards, because as we know, a PCR test is looking for genetic material, SARS-CoV-2 genetic material. It's going to pick up this material. It's not always just going to pick up a culturally competent virus that's capable of replication. So it could just be someone who's still testing positive, but they're actually not infectious. So here's the testing frequency recommendations according to the community transmission level. So if you're thinking back to that map, there's low, moderate, substantial, or high. Low is blue, and there's actually no recommendation for testing staff who are, whether or not they're up to date with their vaccination. Even if they're not up to date, if community transmission is such that it is low in the parish in which your facility is located, there's no routine testing of staff. Moderate requires testing once per week, and substantial or high, as I mentioned, that triggers twice per week testing. Now, just a little footnote here, staff who work infrequently should be tested within 3 days prior to their shift, which includes the day of their shift, if they're not working consistently, several days a week. So Andrea mentioned this a little bit. The idea is to check 1 day per week, ideally the same day per week. If you forget, you can use that time-lapse feature that is new to me that Andrea shared with everyone. But if your facility moves to a higher level of transmission, then the testing frequency should immediately shift to match that higher level of transmission. However, when you go to check on your prescribed day of the week, if your community transmission has decreased, and it would decrease the frequency of testing, don't decrease yet. We want to see, and I'm including myself with CDC and CMS, they want to see that the community transmission stays at that lower level for 2 weeks. And if it stays there for 2 weeks, then you can go ahead and decrease your level of testing frequency to match that lower community transmission. And this I wanted to highlight, perhaps I should have put it earlier in the presentation, but I just wanted to show folks what we're talking about with regard to the number of staff members that might need to be tested because they are not up to date. Because this is really an area where some substantial improvements can be made that will not only better protect that staff member, better protect the residents, but will also decrease by an incredible amount the amount of testing that needs to be performed. So if you're just looking statewide, over here, this is staff vaccination status on the right-hand side. This green portion of the bar, that represents the percentage of staff, of nursing home staff members statewide that are reported to be boosted. And for the most part, everybody's pretty much eligible to be boosted at this point. So it's only 26.5% overall, and certainly it's higher in some areas than the others. The other bars represent specific public health regions. But only 26.5 would be exempt from routine staff testing because they're up to date. So the more encouragement and incentivizing and the more progress that can be made with those staff members that are not yet boosted but are eligible to be, the less they'll have to be tested and the less testing will have to be performed on the part of the nursing home. So I did want to just flag that for everybody. Okay, so now we're moving into symptomatic testing, which doesn't take vaccination status into account because residents and staff, and this goes for the general population as well, anyone with signs or symptoms of COVID-19, regardless of vaccination status, needs to be tested immediately. And of course, appropriate measures for isolation or exclusion from isolation, proper isolation of a resident or exclusion from the workplace for a staff member until the results of that test can be, that are available, needs to happen. Antigen tests can be used for this purpose. But this is where I mentioned there are some situations where an antigen test needs to be confirmed by PCR. And one of those situations, if you have a symptomatic individual and they test negative on antigen, because sometimes you can have positive and negative, false positive or false negative tests on an antigen, those negative test antigen results on a symptomatic person need to be confirmed by PCR as soon as possible. We want that second confirmatory sample to be collected within 1 to 2 days. I prefer within 24 hours, but certainly no later than 2 days. And again, we need to make sure proper precautions are instituted, especially if we need to wait on the confirmatory results from a PCR test. If the confirmatory PCR is positive, then that individual needs to be considered to be infected. A positive antigen test in someone who's symptomatic does not need confirmatory testing, and that person should go ahead and be considered to be infected with SARS-CoV-2. Okay, moving on to outbreak testing guidance. So, outbreak, as you all know, outbreak in the context of a nursing home is considered by CMS and CDC, is defined by CMS and CDC in different ways than we typically think of an outbreak. If we're thinking of a flu outbreak or if we're thinking of a norovirus outbreak, usually it's more than one single case. It's going to be, a couple of cases. But in this context, because of the devastating consequences that SARS-CoV-2 has and can continue to have on this patient population, we have a very, very low threshold, right? So even a single case in a resident or staff member triggers some additional testing. Now, there are two options. One is that testing can be targeted in conjunction with contact tracing. If a facility is able to complete contact tracing, identify a case of close contact, then the residents and staff that have been exposed, that are considered to be exposed, need to be tested, and this is regardless of vaccination status. If this testing reveals additional cases, then you need to expand the scope of the testing. Facility-wide or group level, for example, just a particular unit or a particular floor, other specific areas that a facility determines might have been impacted, that approach can be considered if all potential contacts can't be identified. And sometimes we understand, and through the nursing home survey, it was reported to us that some facilities don't feel they have the capacity to do that level of contact tracing. So in that case, there are two options. If it's perhaps just some guidance that's needed in order to help understand where they need to start and where they might need to focus and what questions they need to ask, then our regional epidemiologists and folks from our HAI team can assist with that effort. If, however, more is needed and that just does not seem to be feasible, then that's when the broad-based testing needs to be employed. And so that's performing testing for all residents and staff, either facility-wide or if it's only one unit that's affected, then that particular unit. And this, again, is regardless of vaccination status. You want to do it not sooner than 24 hours after exposure, but fairly immediately. Usually it's at least 24 hours before an exposure has even been identified, so it's not that piece usually doesn't enter into account. Usually by the time someone tests positive and contacts are identified, then it's been at least 24 hours. So you can go ahead and test immediately, and then if negative, again, 5 to 7 days later. If there are no additional cases that are identified during this broad-based testing, then outbreaks can be discontinued after 14 days on the condition that no additional cases have been identified. If additional cases are identified, testing needs to continue until you go 14 days with no new cases that are identified, and testing needs to occur every 3 to 7 days, depending on the number of tests, the number of positives that are identified. If a large number of positives are identified, you want to use that shorter time frame, and you want to test frequently because you know that there might be widespread transmission occurring, and you need to move quickly to detect those new cases and isolate and quarantine as needed. And also, if antigen testing is used, then more frequent testing should be considered. So I wanted to just go over the confirmatory testing again. So there are two situations when antigen testing is being used where a PCR needs to confirm that antigen test result. And that is when an asymptomatic individual tests positive by an antigen test. And that's important, especially for the residents, for example. As I said, we have false positives and false negatives with an antigen test. The PCR is really the gold standard. So when we have discordant results, we're going to rely on the results of that PCR test. If an asymptomatic individual tests positive, we want to confirm by PCR. Think about what might happen if a resident tests positive on antigen, but it turns out to be a false positive. If they happen to be cohorted in a room with another person who is actually a true positive, then they have a really high risk of becoming infected at that point when they were not infected to begin with. So that's when we want to do that confirmatory testing if an asymptomatic individual tests positive on an antigen test. Again, as we mentioned when we were talking about testing following symptoms, if a symptomatic individual tests negative on an antigen test, we want to have confirmatory PCR there as well. So again, this is about the time frame. The time frame is very important. We would like to have specimens for confirmatory testing collected within 24 hours after that initial antigen specimen was collected. It can be up to 2 days. Again, I prefer it to be sooner than that if possible. If you've got more than 2 days, then what happens is you could potentially have another exposure that occurs, and you don't know if that PCR is positive, if it's related to potentially a new exposure, or if that original antigen test was actually a false negative. And so that complicates the situation in terms of contact tracing. So really need to have that specimen collected within 2 days, ideally 24 hours. Okay, so I did just want to talk that concludes the update related to the testing overview. I did just want to, I know that I went through it fairly quickly, but again, we'll have that resource document which includes all of this information all in one place for you all. and I think that's going to be a good quick reference guide. But I did want to talk about a reporting update because in the survey that we conducted, there were a lot of questions and concerns about reporting. And one of the questions was related to some new HHS guidance that came out, I can't remember, it was a few months ago maybe. HHS used to require on a federal level reporting of all SARS-CoV-2 tests regardless of type and regardless of results. And they have changed that. What the big change is that antibody tests, regardless of whether or not they're positive or negative, no longer need to be reported. And this is a federal guidance. In addition, antigen tests do not need to be reported if they're negative. They only need to be reported if they're positive. PCR tests, regardless of results, if they are positive, if they're negative, if they're indeterminate, if they're critical, those need to be reported to us, all of them. And so we are aligning with that HHS guidance in terms of these changes in reporting. So as facilities, and I presume a lot of facilities are going to shift toward using the antigen test for the routine staff testing, you will not have to report the negative test. We'll only need to report the positive test. So I think that's going to certainly make that reporting a little less burdensome. I just wanted to touch on masking, as I mentioned at the beginning when we were talking about being up to date, and we're talking about vaccination status and community transmission being two components that were important in determining staff testing. And it's also important for thinking about masking. And so I did want to just cover this quickly. Basically, CDC, and this is straight from CDC guidance, CDC recommends source control or masking and physical distancing in any healthcare setting as is feasible. Now, they do allow for certain sort of exclusions or exemptions from this masking in certain situations. But these situations involve when the community transmission is either low or moderate. Substantial or high community transmission, the risk is such that really these situations where it would otherwise be exempt, you need to mask in those situations. And it also includes the individuals involved being up to date with their COVID-19 vaccination. So you can see that some of these situations are healthcare providers who are up to date with all COVID-19 vaccines. They could choose not to wear source control or physically distance if they're in areas that are restricted from patient access. So if they're in meeting rooms or a kitchen, still, regardless of vaccination status or community transmission, when they are in patient care areas, they need to mask. But again, if a healthcare provider is not up to date, or if a facility is in a parish that's experiencing substantial or high transmission, then this exclusion does not apply. Patient visitation, I'm not going to read all of this, but essentially if the patient and their visitors are up to date, and again, I would take community transmission into account here as much as possible, keeping it at substantial to a high transmission where you really are encouraging everybody to mask regardless of vaccination status. And then residents, this specifically applies to nursing homes, who are up to date in areas of low to moderate transmission, they can remain unmasked in communal areas of the facility. But of course, even in areas where they're experiencing low to moderate transmission, residents who are at increased risk for severe disease should really still consider continuing to wear source control. So I just wanted to go over that. That's very, very quick. You'll have the resource here, and then I have included the link for the full detailed guidance. I just wanted to acknowledge some folks who have been very, very critical